Good morning, everyone, and a very warm welcome once again to the Day 2 of Second International Conference on Transforming Healthcare with IT. Yesterday, we witnessed some amazing sessions that provided us with thought-provoking insights. So let us continue this journey with more such fascinating sessions. Every concept in this conference relates to transforming healthcare with the help of IT. And IT in itself is incomplete without informatics. Who else could be a better and an appropriate person to chair this session than Dr. Shiban Ganju, the past president of Indian Medical Informatics Association, New Delhi. I request Dr. Shiban Ganju to conduct the proceedings. Ladies and gentlemen, let's welcome him with a round of applause.
Thank you very much, and thanks for coming here this morning, early morning on Sunday. And let's have the panelists here, please. We'll not waste much time. We'll just get started now. Thank you.
Check. Hold on.
The topic of today's first panel is Health Informatics, the key to transforming healthcare. Our first speaker is Dr. Gogia. He's the past president of IAMI. He's the president of SATHI, which is the Society of Administration of Healthcare Informatics, and chairperson of IMIA, a working committee, the head of the working committee in telehealth. He's a graduate from AIIMS, Delhi, and is a practicing surgeon, Dr. Gogia. He will talk on what really is medical informatics. Thank you.
Yeah, thank you, and it's best to have the first session and the first talk on something which everybody knows anyway. So, it's just to keep the things happy and going. Anyway, my introduction has already been made, so I don't need to go into that. I'll be talking about what is MI, which is medical information. Basically, I'll be talking about who are the professionals and what is it, where and when does it apply, and why and how is it important for this thing. But, I've always said that whenever I make a talk, it is, I say everything at the start, I say everything in the end, and I let people sleep in between. If they want to listen, it's fine, But in the morning time, the people who have not come will not be missing anything. Basically, it has been very well stated yesterday by Professor Muir Gray. It is value. This is medical informatics, is value addition to what all medicine is doing. That is what the summary of my statement. If you go by definition, it's an interdisciplinary field of study that emphasizes the use of computer technology to help organize, analyze, manage, and use information in improving healthcare. Its chief goals are to develop standards and clinical guidelines, formalize medical technology, enhance the usability of health information systems to facilitate communication, and manage the flow of information from physician to patients. There is a little more to it, but this is the summary which I have taken up from the net. So I think it is fairly succinct. Oh, sorry. Oh, sorry. I don't know how to use it. Okay. But if you want to really classify medical informatics and, what are the various components of it, this is how you go about it. It largely started, and this is what is taking place, are the administrative tools, which take care of your billing and stocks which you work in hospitals or any clinic. Then there are the general research tools which you are using, which is basically for record keeping, and EMR, which is the master, and a PACS is an addition to that. Another aspect of medical informatics is knowledge management. Use of the internet by medical professionals as well as patients, online journals and searches. And another component which has increasingly come into prominence is online conferences and webcasting. Actually, the last healthcare informatics conference was webcast. I don't know whether this one is being, but we are reaching a stage when we really don't need to meet to share knowledge. It can be done online, and this is a large component of medical informatics should be called upon to it. The basic idea is to use IT as a replacement for travel. Because the information travels, you don't need to travel to get the information. Then it is also used specifically for doctors and others. They create websites, they create commercials, they create their own knowledge enhancers to promote themselves. And you can send personal mailers to your patients. Another concept which largely this conference is about, and where Apollo actually started, was telemedicine. CDSS, CPOE has been talked about yesterday, is going to be talked about lot next, and telerobotics is the fanciful thing which has been used and will continue to be used. But overall, medical informatics can be divided into two components: the medical, which I believe should be the master, and informatics is actually the slave. So what does a medical person do? He does patient care. So informatics enables the patient care. The problem is when people think that informatics as the MI is the end in itself, they try to give patient care as the informatician is a patient care provider. He is not. A medical person has to have knowledge, and informatics can be used to enhance the knowledge. The medicine plus does procedures. To some extent, through robotics and all that can be done through medical informatics. But the important thing is that, this thing has got varying costs. You have costs for primary going up, to secondary and tertiary care. Informatics can provide value addition, but sometimes it is the reverse. You spend too much on technology, and it becomes a sort of an end in itself. And some cost reductions do take place when we actually apply medical informatics used in a proper manner. It may or may not be used. That is a moot point that we'll just be touching about later also. So these are the people involved. We have administration, and I've already said about general who do. These are the four main components of MI actually. HMS, HIT, the involvement of clinical profession, which is basically EMR and its offshoots like CPOE and CDSS. I hope you all know what CPOE and CDSS is, so I don't want to expand too much on that. But so the administration does billing, stocks, staffing, maintenance. That is also part of medical informatics. Nurses are doing nursing informatics, taking the patient, the general care records. And public health has got a huge role, where informatics has a huge role through epidemiology. And in fact, the big concept of e-health is actually an offshoot of what was telemedicine, and it gradually traveled backwards. So now e-health is the buzzword, which all of us have been discussing even yesterday also. And radiologists and lab services has been a big beneficiary of IT. Then, besides the clinical things, we do have what are called knowledge management, which is basically can be managed by an IT officer or a knowledge management officer. In fact, there are specific jobs which have been propagated for medical information as a knowledge management officer in the hospitals. And library sciences and education. There are some talks on education today after this session also. HMS, now just expanding a little, is basically an ERP for a hospital. I actually believe that without an EMR, and a lot of these HMS systems do not have a proper EMR, I call them hotel management systems. They're suited for administrative needs. There's some amounts where the medical part is the model, so all the things in red are not actually medical. They are informatics, yes, but they are not medical. So I wouldn't call them medical informatics, but yes, they are important for the running of any medical establishment. That is true. So, things like a pharmacy, a duty roster for nurses as well as is part of medical informatics. Taking care of the CSD, because these procedures are not found outside of a hospital. That's the reason I'm talking about them. The rest can be found anywhere else. So HIT is nursing informatics, which I already talked about. We talk about drug orders, create checklists of what all has been done at the time of admission, at the time of discharge, in between, during the ward rounds and all that, what has been done. There's this thing for systems for labs, in which we talk about machine interpretation and direct incorporation into your reporting tools. Radiology and packs have been talked about, and there's a display out there also. We all know about it. And telemedicine and e-health again have been already discussed, so I'm just barely mentioning them. And epidemiology and remote monitoring which is part of home health care, is definitely medical informatics. But the basics for all medical informatics, I believe, should be the EMR. Unfortunately, this is where all of us have been lacking. EMR is not being used to the extent required. So this is what I tell the clinician when I want him to start using EMR, because this is going to enhance his practice and enhance medical care, is that record keeping is binding on all doctors as per the ruling of 2002 by MCI. And in fact, use of EMR increased slightly after the CPA came up, because if you are not keeping a record, you are 100% liable for whatever you have done, whether you have done right or wrong. It helps efficiency, better patient care. It's a moot point whether it provides savings and all. It's important for research. Any research-minded person should use EMR in day-to-day practice. It helps you avoid mistakes, helps in auditing, helps in information sharing. But if you look at it, why do doctors use computers? It's a personal thing. I don't want to put it on record. It's a fact that most doctors use it for internet and email. Some of them use it for games. Mostly for a glorified typewriter, you use your Word or Office documents and just send them across. For presentations, yes. Unfortunately, this is one thing which have been noting even in all these things. Doctors make much better presentations as compared to IT people. I don't know for what reason. The IT presentations I've seen are very, very small reading fonts. Probably they're more used to presenting in small boardrooms and not in big meetings, while doctors are used to presenting in things. And making presentation, I think, should definitely be a part of medical informatics. Whoever wants to start a course on that, it's very important how to share the information and give it to the people. Very few doctors, 10 to 15% of doctors do keep patient records, but a proper EMR in India at least is found in only 2 to 3% of doctors. While if you look at what is happening in the US and Canada, is something a little better, but still it is not ideal. That is. Overall, IT can help you creating faster work, because one of the main things which doctors complain about when they're talking about it is, I don't know how to type. But you must learn a little bit of type if you want to take on. And if you start using it, in no time, you will be creating output and creating better much faster than writing. This is what we try to say. If you have a proper EMR running at your place, you can spend all the time with the patient and a very little time in time, because the reports come automatically. There's so many tools in your EMR and this thing in the report, and because reporting has to be part of your EMR. If it is not, then it is not a good EMR. So we know all this, that a keyboard you can type faster if you have training. A spell check, error check is possible with the keyboard using all the tools and all, but with the hand it's not recorded because it comes automatically. You learnt it at birth. You can create multiple copies, but if you want to keep multiple, it takes very, very long. Then neatness, access to that, my time is finishing off, so I'll just run through the rest. So the other aspect is improving knowledge base, which we have already talked about. Simulation techniques, presentation techniques, I've already said. You have online discussion groups, but it does have problems. It sometimes becomes too involving, especially at the start of your career. And there are technical problems that, your network card is not working or your light has gone off. This can really disrupt your working as a doctor. you do require a proper system to be in place to run a proper MI these things. There's a learning curve. There's obsolescence. Whatever you bought 6 months back has already gone out of this thing. But the biggest problem that we find in MI has been what is called a technology hype. A lot of people say what is called the can do and will do syndrome. It will do this, it can do this. Finally, always when you're going for medical, say what has it done? If it has done something, it is going to be good for you. Will do and do the are really these things. There are some fears like the tax man will come and these all, I don't want to spend time on this, but these are fears only. An important part of it was touched upon yesterday, what is called change management. If you really want to go in for IT, you have to really start a gradual change into this thing, and the change management has to be part of the whatever you purchase. And it has been well said that success of a project depends on 20% on the technology, 35% on business process re-engineering, 40% on change management, and 5% on luck. So I'm not spending time. There is a definite need for capacity building in this. And if you use it properly, it does have outcomes. This is our own product which we have used in Indian Spinal Injuries Hospital. We were seeing 45 patients in a day over 8 hours previously. Now we see more than 60% a day in less than 5.5 hours. This is the sort of change which technology has brought about in our clinical care. The last slide, I don't know what happened to that. Anyway, thank you. Sorry, there was the last slide. I don't know, it's gone out. Gone blank. Thank you. Sorry.
Our next speaker is Madhu Arvind. He's a Stanford grad and he's the CEO of Health Highway. Madhu Arvind.
Is it on? Okay, thanks. Okay, so I'm just going to spend the next 12 minutes talking about one specific topic. So yesterday we've heard a lot about what IT can do for providers, for patients, for various other folks who are concerned with the healthcare ecosystem. But this topic would specifically be surrounding what essentially technology can do for providers to bring patients in the loop. So that's the only focus of this topic. So I'm just going to start with a very simple story that essentially I had to go through 3-4 months ago. So my wife, she was having 103 fever for more than a week, and we had been seeing a couple of doctors. And finally, it got so bad that we had to take her to a hospital. And this is one of the super specialty hospitals in the country. So I take her there, and they ordered around 10-15 tests, and the tests were going on. Some tests were available the same day, some tests were available 3 days later. At any point in time, I wasn't sure when what is going to be available. And since I was essentially the only person with her, I essentially was running around trying to find out when am I going to get what results. And so after the long story, she got admitted because the doc said that it's better to keep her under observation. And once that happened, the story took a slightly different twist. So she had a lot of, her family, there were a couple of deaths due to allergic reactions to medications. And so whenever I take her to any facility, I always make it a point to say these are the 5 things that I know of that she's allergic to. So I gave that information to the doc right ahead of time, and she was given various kinds of antibiotics at various points in time. And at any point in time, I never got the confidence that they knew what she's allergic to and what she's not. Because the reason I'm saying is the person who's coming will always ask me, hey, you know what, I'm giving this new antibiotic. I asked as a doctor, check these things, and the answer that they give me was never something that is convincing. And then they wanted to take her to a CT scan, and the guy who's doing the CT scan asked me the same question, what she's allergic to. I'm like, shouldn't you know about this? I've given the information already. Okay, so, I'm like a thoroughly confused person in that ecosystem. And then when it comes to billing, so I'd paid X amount of money as deposit. And at any point in time, I just don't know what is the outstanding bill. So I was in the hospital, or she was in the hospital for a week. And during that whole process, it was a really time-consuming and frustrating exercise to find out how much essentially is the price or the cost at this point in time. So the only point of me saying that story is today the journey of a patient through a hospital is not that simple. It's actually it's a story where people are in the dark, especially the folks who are with the patient. And irrespective of the assurances that the doctors give that they are in control, they know everything, having been in the healthcare industry for some time now, both in India and the US, I always take that assurance with a grain of salt, and I'd want to see a little bit more transparency in that process. So the next few slides are going to talk about what that transparency means and what one can do about it. So what I said is one aspect, like the confusion of someone who's going through a healthcare ecosystem, let's say a tertiary care hospital. There is also another aspect where that care we are talking about with the doctor is only a small subset of the overall care that we need. And I'm not going to go to this point in general because there are a lot of folks who are going to talk about wellness and prevention and so on and so forth. So the only 2 points I want to convey is one, the journey of a patient through a provider is not that simple today. It's less transparent. And secondly, you keep aside that and you look at the overall ecosystem, the access to the overall healthcare is also fairly complicated. Now, when you actually see what is the state at a hospital, and this is a point I'm not going to belabor because it was talked about a lot yesterday, there are various silos in a hospital, be it HIS systems, PACS systems, telemedicine systems, a whole bunch of systems are there. But more important than that, all of these systems are, even though, and one thing is they are in silos, secondly, they are all very internal focused. They are all trying to kind of improve the efficiency of care delivery within the hospital, which is great. But the customers of hospital are predominantly outside, like patients, be it corporate customers, be it other stakeholders like insurance companies even. And they are not really part of this IT loop or a process loop that is there. So that is one of the fundamental things which I'll talk about in a second. And just one data point, which the slide I think is very dense, but the only point I want to kind of communicate by this is the fact that across the world, people evaluate providers not only by the quality of clinical care that they give, but also by the non-clinical aspect. And this is from a McKinsey study, which is again common sense, where for those who can't read that, what it really says is being kept informed and timeliness of appointments are two key criteria that patients and their bystanders are really caring for. Now, when I took this example to the management of the hospital and the doctor, what they kind of told me was, hey, our business is providing high quality care and nothing else. And the rest of it, I can't be in the business where I have to keep you in the loop or keep the patient in the loop and so on and so forth. That is all very time consuming and I can't do that. So, straight answer, fair enough. So they consider their business as improving the quality of clinical care that is given. And what that kind of reminded me was the same kind of analogy that is given probably 10, 12 years ago in a different industry. And that is in the telecom industry. And the only example that I want to give here is, if you looked maybe a decade ago, a little bit more than a decade ago, there was a telecom boom along with the dot-com boom. And the kind of companies that were trying to conquer the world those days were, the service providers, the AT&Ts of the world, a lot of folks who were providing hardware equipment. And they all were the folks who people thought that, hey, they are the ones who are going to really benefit from the telecom boom. Now, what happened 5 years later was that the companies who actually benefited from the telecom boom were not those. If you just look at even a market cap of a company as an example, today, let's say Verizon has a $100 billion market cap. Apple has $330 billion. The only difference between a Verizon or an AT&T or even a Nokia and an Apple has been their approach towards their consumer. And I'm not going to talk a lot about it, but just want to spend 1 minute on it. So when the Nokias of the world were ruling the world, the notion was that a high quality handset on a high quality network would actually be the thing that the consumer want. Well, great, it worked well for a while, and then Apple came along. Their handset was neither high quality, if in terms of purely from a voice data perspective, and neither was a service on a very high quality network. But the results speak for themselves. Today, Apple has revolutionized the mobile space. And there's only one real thing. They said rather than trying to focus on the core infrastructure, let me try to cater to the needs of the consumer. And what they did was, I'm going to try to provide tools and services that an end consumer would want to use for their day-to-day activities. And that shift from a very infrastructure-focused approach to a consumer approach actually revolutionized the mobile space. And if you look at India, the same thing. The Airtels of the world were the kings of the world when they were focusing on, hey, I need to build more cell towers, I need to build more infrastructure. But if you see today, there is a trend where the amount of money that the service providers are trying to make from value-added services is constantly going up. And the reason I bring that point up is value-added services means you have to provide something that is meaningful for the end user, and that essentially is a shift to consumerism. So that essentially is a trend that is happening in India also. And you can compare this infrastructure approach to the provider segment too, when providers are saying that, hey, my business is to have the best clinical infrastructure. That's the exact same thing the telecom provider said, hey, my business is to have the best telecom infrastructure and the rest will follow. Now, the point I wanted to make from that is the folks who have said that infrastructure is the end game have always lost in the long term. And the guys who won the game, who were the ones who shifted from that to a consumer-focused perspective. Now, what does that really mean? If I say all these things, what does it mean that, how does a provider go from an infrastructure-focused approach to a consumer-focused approach? The first thing is there are various touch points for a patient in a hospital. Let's start with that. So the middle portion here, which I'm talking about customer retention, we got to simplify the interaction or have one phase of interaction of patients with the hospital. Be it appointments, be it viewing lab results, be it access to information, be it pre-registration. Rather than running around, in various desks and so on and so forth and getting confused, we got to have a mechanism where there is one single view for the end user. And so I'm just drawing it, showing it pictorially here. So what we've been doing for some of our customers is, irrespective of whether you have a separate claim system, whether you have a separate corporate management tool, if you have one, or whether you essentially have multiple, PAC systems and HI systems and so on and so forth, any interaction that a patient needs to have is being done by one entry point, whether it's via a website or a mobile device. Now, an example, so one point I also want to mention about the mobile devices, even though there's been a lot of talk about mobile devices, in India, the number one thing one has to ensure is the access to smartphones and so on and so forth is, while it's increasing, the proportion of people who are still having the old Nokia phones are very high. So the kind of technology that we have adopted is something that is even usable in a 3,000 rupee phone, which is actually a very critical point in India. Now, another aspect quickly, since I'm running short of time, is the thing that I mentioned about, the providers being able or should be focusing on broadening their spectrum. The key point that I always hear is, hey, that's not cost effective for me because I have very serious capital costs and so on and so forth. So I have to work on things which make money for me. Fair enough. So the old way of working and catering to the needs of a patient by essentially the totally manual method will not work when you're trying to do prevention, disease management, and so on and so forth. You have to essentially go for a very low cost, cost-effective mechanism. And an example of that is a disease management program that we've implemented at a couple of hospitals. So I'm running short of time. So the last thing I want to just say is, one question that I also get is, why is that I can't just do it myself? A couple of key things. One is, health is a very, very sensitive subject, and privacy models have to be extremely strong in any solution that you build, which means at the end of the day, who sees what information, who can share what information has to be in the control of the individual, and to guarantee that, you need the kind of technology that is not just something anyone can build. Secondly, there are disparate systems out there. You got to kind of bring everything together virtually and have one view for the end user, which also is a complex task in itself. And secondly, you got to do this across providers, in the sense like across facilities. Each one large hospital has multiple feeder facilities, maybe clinics, maybe other hospitals, and you got to kind of have one view across all of them. And to do that, essentially, you need a kind of technology that is not the most obvious. So anyway, I'm stopping my talk with this. For any further questions, you can either email me or come to our booth in the stalls. Okay, thank you.
Our next speaker is Dr. Bhattacharya. He'll speak on clinical analytics. Dr. Bhattacharya is the current president of Indian Association of Medical Informatics. He also heads the Health Informatics group in TCS, and he's involved in designing EMR and clinical analytics. Dr. Bhatta.
Thank you, Dr. Ganju. I would like to first thank the organizers for giving me the opportunity to speak over here, as well as I would like to specially commend them because my talk would be mostly on something that would be a natural follow-through of what Dr. Gogia said and then what Mr. Arvind was mentioning about. And particularly, it is interesting that I'll be talking about the theory and Dr. Karanveer Singh will be talking about the practice of clinical analytics. So let me just go without further ado as to what is my agenda. I've put it into 3 buckets. The first one is what is clinical informatics or clinical analytics, sorry. The next one is analytics in healthcare, how we do it. And the number 3, I'll give you some examples of what clinical analytics is all about. Now, what is clinical analytics? Please understand one thing. If you do not have an EMR, you cannot do clinical analytics. And it is the clinical analytics which will help you to do a better job. When I say better job, it is not only giving better care, but trying to contain the costs at the same time. So let us see how it goes. The definition is, if you will just see at the top, clinical analytics is the analysis of clinical data, including clinical observations, investigation results, and past treatments in determining a diagnosis and treatment regimen. So what happens is this, that it tries to analyze the past data, all clinical data, but it also calculates how much it costs. And then you try and figure out what is the best way to treat the next patient or the patient in front of you. Outcomes are driven by improved clinical quality. So if you want to have better outcomes, you need to see how your quality is improving. It is no good just to assume certain stuff. You need to see, you need to visualize, and you need to have evidence for it. Improved quality can be achieved through increased patient safety and satisfaction and a focus on regulatory compliance. Now, you also have to comply with certain regulations, which every country has, and wherever there aren't any, as soon as we have healthcare IT coming in, a lot of these regulations are put in place because of the issues of patient security and privacy. But you also are looking at increased patient safety. We had another conference going on patient safety, and you need to take care of that. And you have to also take care of patient satisfaction, which Mr. Arvind was all talking about. The patient got the best of care, probably. But was he satisfied? Is it not a business to see that you get your patient satisfied? And it's the overall experience. It's just not getting better. Today, the expectations are larger. When you pay a lot of money, you expect value for money. What are the aims and objectives of clinical analytics? Clinical analytics aims to provide clinical care providers with sufficient information so that they may devise and monitor better personalized treatment plans. See, the whole game now is going to be that the patient in front of you will have unique requirements for treatment. You cannot treat him as you would treat every other patient. So we are looking at personalized care. And personalized care is possible. But only if you do have electronic medical records, which ultimately also has an electronic health record. There are two distinct records types. And then you have clinical data repository. You devise and monitor and refine better treatment protocols. You design a treatment protocol for a particular disease or a condition. But then, is it good enough? You heard yesterday one of the doctors speaking about that what he was doing 7 or 8 years ago were no more valid. What happened? What changed? You can track your changes. Provide ever better care. This is what we all clinicians want to do. And provide best care at least costs. What is the future? Dependencies. You're going to use clinical analytics, fine. But what are the dependencies? Why are they happening? What is driving clinical analytics? Now, this is probably not very applicable for India, but our incentives, EHR, meaningful use compliance, and ICD-10 adoption will lead to steep and rapid increase in available clinical data and ability to perform detailed analytics. See, previously the challenge was you never captured the electronic data. Clinical analytics is still being done, but paper-based records have its own challenges, and you cannot do it in real time. But if you have electronic records, you can do it in no time. You can actually get it in real time. Now, how is this happening? Why is electronic medical records coming more into picture? It's simply because of these factors. Well, when there is money available, you would like to be, that's an incentive for you to use them. Meaningful use is actually trying to make doctors in US use more electronic records. The follow-on would be that they would become more and more ubiquitous as people get more confidence in it. The challenges that are apparent or people think that they are there, that it's very difficult to use, you have to type, etc., etc. All those things will come down as people see that the benefits outweigh the trouble. Patients, providers, and payers are all looking for ability to deliver quality care at a cost-effective price. This is a no-brainer. Appropriate software needs to exist that houses data in a form that can easily be analyzed. Dr. Karanveer Singh will give you a practical example of how that is being done. Clinicians must be willing and able to capture information in discrete data fields. What is happening is the paper-based records, it's mostly free text. Not mostly, but almost always free text. And it exists, the data is all there. But to cull the data from there, it is a human's effort. But if you capture it in an electronic format, but not free form, free text form that is, you must capture it in a proper data format. Otherwise it becomes very difficult. You can still do text mining, but that itself is a lot of challenge involved. Organizations must be willing to invest in the data analysis from both staffing and tools perspective. These things are not cheap. Let me be very, very clear about this. Because they give you a lot of value, but there are a lot of technological challenges which are involved. Dr. Karanveer Singh will show you all that. That you can just begin to imagine the trouble that you need to undergo that is from the technical point of view, in order to get all those lovely numbers out there. The challenges are going to get amplified as pressures due to EHR meaningful use compliance requirements. Now this is actually one of the requirements of meaningful use is that not only you have an EMR, but you also get reports out. And believe me, this number of reports will get more. So more information will have to be made available to the government, which actually is also that it will be available to you. The answers sought will get more complex, that will require higher skill set and more complex analytical tools. There is an answer sought by the patients, the providers and the payers. The clinicians will also have to seek those answers, because the example may be analyzing the genetics and proteomics of people to begin to assess the impact of these factors on their conditions and response to treatments or specific medications. We are now getting into the genetic profile. So what will happen is that you will need to match the patient's genetic profile and find out what all medicine works for him the best at the least cost, and then give that medicine so that the least complications and faster recovery takes place. So what are the analytics in healthcare? Healthcare intelligence. High performance healthcare providers consistently outperform peers over a sustained time frame across business cycles, industry disruptions and changes of leadership by leveraging the power of information using a tool set from other industries called business intelligence. This is BI. Business intelligence is very commonplace in other industries. When you apply it to healthcare, we call it clinical intelligence. So what are the broad healthcare spaces that we are talking about? We have the provider, we have the payer, and you have the supplier. And the important healthcare intelligence that you can manufacture or you can find out are performance intelligence, financial intelligence, and clinical intelligence. These three make up healthcare intelligence. I will be only talking mostly about clinical intelligence. The rest of it, they're already there. All the MIS reports that are being generated are performance intelligence to some extent, and the financial intelligence are, you already have it, all those who have got HIMS. So let's say, what is the data, information and intelligence? What do I mean by intelligence? So let's say we get an information, patient has a BP of 120/80. That's data. Normal population, this is information, normal population has been found to have a BP of 120/80. So if you get that, the patient is normotensive. That's intelligence. Okay, this is very simple. Let's see a little complicated one. Investigation 1 is 90% sensitive for condition A. Investigation 2 is 60% sensitive for condition A. Which means investigation 1 is better for diagnosing condition A. You will not be able to get this without running the clinical analytics. The second one, number needed to treat. Condition B with treatment regime 1 is 4. With treatment regime 2, the condition B with treatment regime 1 is 8. Actually, this should be treatment regime 2, I'm sorry. So therefore, treatment regime 2 for condition B is worse. It takes you double the effort to treat. What cannot be measured cannot be managed. Very simple. You need to have these analytics. Clinical analytics is one way to effectively assess clinical performance. We are not talking about physician performance. We are talking about overall treatment performance. You can always do. The whole idea is to do better care. Better treatment to more patients at lesser costs is the demand of the time. What are the reports? Providing better information for clinical management teams presented in easy to understand formats with high visual impact. We normally use dashboards and graphics. Using multiple sources of existing data even across organizational boundaries. That is just not you, your hospital, the hospitals in the region, the country. It could be all inclusive. And remember, the data that you're going to share is de-anonymized data. It has been stripped of all PHI, personal health information, or protected health information. Everything is stripped out. So you cannot identify the person from whom you got the data from. Providing clinical information relevant across multidisciplinary teams is not just your discipline, it is across all disciplines. Displaying information in real time without delay for data cleansing. allowing local configuration and comparison against national data sets, permitting regular on-demand changes to display and keep the information relevant and up-to-date. The usefulness is cost savings, improved margins, improved patient satisfaction, better care. What are the sources? I'll skip this. These are very commonplace. We all know this. We concentrate on mostly EMRs, departmental systems, equity and accounts receivable and payable. The steps are 5 steps. You design the question, you develop the questionnaire, you capture the data, you run the analytics, you present the reports, and some of the indicators that we have. These are mostly for guidance. There are plenty of, these are just a very, very small subset of the types of data that we can analyze for you. I mean, the analytics that is there. Thank you very much.
Thank you, Dr. Bhattacharya. I wish we had more time. This is an extraordinary subject, and thanks for extraordinary presentation. Dr. Karamveer Singh is our next speaker. He's a practicing surgeon and also heads the health informatics group in Sir Gangaram Hospital in Delhi. And Dr. Karamveer Singh will talk on data mining and business intelligence in a hospital setting.
Good morning. Dr. Bhattacharya has very nicely introduced my topic, making it easy for me. And I'm going to talk about experience of Sir Gangaram Hospital in using data mining and business intelligence over the last 3 years. Actually, business is not something that hospitals do primarily, but this is the breed of software which we have taken from other industry, and that's the term that is used, business intelligence. Now, what do these words mean? Data mining means the process of extracting patterns from large data sets by using method from statistics along with database management. And business intelligence, as Dr. Bhattacharya said, is looking at the data and getting intelligent information out of it. So what is the necessity? Hospital information systems capture huge amounts of data. And most hospitals are able to analyze the data in the form of reports, but they're not able to analyze it. I will explain the difference now. Look at this. This is a report we made when we had first started our HIS years back. This took about a week to make. It is a 10-page report and gives information on the statistics of various outpatient clinics, the patients who have attended, male, female, child, age, etc. It runs into about 10-12 pages and takes about 10-12 minutes to run for a 1-month period. We have not even tried running it for a 1-year period, leave alone a 5-year period. And suppose someone wants to know, okay, a particular clinic, what is the visit in a particular month? You have to run the whole report. Wait for 10-15 minutes, then just look at that value. Or if you want to analyze patterns, draw graphs, you have to run the report 10 minutes, 15 minutes, or if you are running for 1 year, maybe 4 hours, and then export it to Excel and then do your analysis there. Not a very good method. These are the problems. Someone took days to make this report. You need to export it to Excel. If the field is not there, now suddenly someone says, please show me diagnosis. Show me all the diabetics who attended. Not possible in this. Now someone is going to take days to make the change, and you have to sit and wait, and you may need the report very urgently. And even then, it's going to take a long time to run. So what is the solution? Indexing and data mining. So what is indexing? That's the important thing I want to stress today. So let's assume that I know all your names, and now I have to answer these questions. Hey, I've given some names over here. How many persons have K in their names? Audience, just have a look. It's going to take you some time. How many have R? How many have S? No, how many have all three? Yes, you can find this information, but it will take you something like 10-15 minutes. No, at least 5 minutes to get this information. Now I index this data, and this is index data. I create columns. And now tell me how many have an R. Very easy to see. How many have an S? How many have all three? So you've got Ashok Kumar and you have got Harkishan Batra. It just takes seconds. That's what indexing is. Indexing means counting in advance before the questions are asked. For a hospital, you then have to anticipate what the questions are going to be. And that is the crux. It took us 1 year to set this up. Installing the software took 1 week. And then it took us 1 year to understand what are the potential questions that could be asked now or in future, and indexing those. So what is indexing really in hospital information systems? All hospital information systems will index data to some extent. But because they have to search, so if you're searching by registration number, patient name, they have to give you write Ashok Kumar, they have to give you a list of all the Ashok Kumars. Otherwise, HIS is of no use. HIS cannot say, wait for an hour, I'll tell you which Ashok Kumar or which Ashok Kumars are registered in the system. So they will index certain data, commonly indexed parameters in a standard HIS are patient name, age, sex, registration number, admitting unit. But everything is not indexed. Because if you index everything, your HIS will grind to a halt. It will become very slow. So that's where your data mining software comes in. We use Speed Miner. We got this from a company in Malaysia, Hesper. What it does is, it mirrors the HIS data, it copies it on a separate server, indexes it there, so that the main HIS server is not impacted and does not slow the HIS. So what have we used it for? We have used it for internal process measurements. We have used it for patient flow elimination of process delays, compliance with mandatory reporting. For instance, one of the common reports that the government asks us is to send us a monthly list of all the ICD codes for, say, ICD code for tuberculosis, how many patients have come, ICD code for miliary tuberculosis, ICD code for this type of tuberculosis, that, I mean, everything. So we have to provide a list, mandatory. Performance analysis of doctors, who's getting how many patients, what is the length of stay, number of operations, etc., earnings. For the whole hospital, length of stay, hospital costs, revenues, operating margins. And we have extensively used it. Clinical data analysis, physician compliance with hospital protocols, how many patients came in with MI and had an aspirin given in the first 1 hour. We are using it. Analysis of disease patterns, patient demographics. And BI can produce its own data for evidence-based medicines. So I'll give you an example. What we have is you pick up all the diabetics, say non-insulin dependent diabetics, and you see what are the comorbid conditions that they have. And you can divide it by age. So you know, okay, patients presenting with diabetes are likely to have these conditions. In this age group, these are the conditions common. In this age group, these are the conditions that are common. Yes, you can get it from textbooks, but we are getting our own data, which is specific to the area that we cover. We have used it for inventory management, purchase, stock transfers, patient, staff, and physician satisfaction. And now I've got some demonstration videos, because what I have spoken really doesn't mean anything to you. I want you to have a look at the videos and see for yourself what we are doing. So this is the screen. I'm going to show you the video afterwards. This is our data mining screen. And do we have a pointer? Yeah. This is the dimensions. Now, what is meant by dimensions? The questions, I've anticipated the questions are going to be asked, and I have indexed the values. So for instance, here over here you have admitting source. So does it come from casualty, from private OPD, general OPD, born in hospital? I know someone can ask. So I've indexed that. These are all the indexes, and this is actually a scroll bar. So this runs into something like about 40, 50 indexes for this area. This is your demographics. Clinical has something else. But totally we have about something like 40 areas, and each will have an average of about 20, 30 dimensions. So we're talking of close to 1,000 indexes that we have done, as opposed to just 10 indexes at the most, which are there in the HIS. These are things I can study. Counts, the number of cases, number of episodes, etc. I can define my rows, columns over here. This is the find button. So we'll run the videos. Before running the video, I'm going to ask a question. So suppose there's a doctor who has come next to the person in the IT department and says, okay, show me total number of patients who's ever visited the hospital. Okay, you run a report, you get it. Next question he asks immediately is, break it up by episode type. How many inpatients, how many outpatients, how many in emergency? Imagine you're making a report. You'll say, okay, 10 minutes, 15 minutes, come back. He comes back and he says, break it up by patient 6. You never thought of it. So now you're going to make the report again. Show me age and admission ranges for a particular group. Show me the admitting unit for a particular age. So you narrowed down to a particular age group, show me the admitting unit. The diagnosis within the subgroup, details of patients within a particular diagnosis, which tell me the names of these patients. And export the data to MS Excel so I can take it home and publish it or whatever it is. Now imagine if you are making a report. It would be a 1 or 2 day job doing all this. And I want you to appreciate the speed at which this happens. This is a real-time video. I have not speeded it up at all. Here's the one. It's a 2-minute video. Okay, so I'm going to click first on the find button to get a total number of patients. I've got these 29 lakh patients over here. It just took how much? 1 second? Now I'm going to analyze by episode type. I drag and drop it there. Half a second, it breaks up into emergency, IP, OP. Now patient sex, I drop it on the inpatient. It breaks it up immediately. Female, male, unknown, okay. Then age and admission ranges, I drop it over the female one and breaks it up immediately into the different ranges. I can click on a button and see it as a bar graph. And you can put a cursor on each and you can get the value. We'll go back to the chart again. I'm following this question list that I showed you. So I'm going to take a small period and drop it over the 20 to 30 years group. It's broken down. Real time. You cannot get this analysis using reports. So I'm taking an admitting unit and analyzing it for January this year. Breaks it up by the admitting unit. I take the diagnosis and I drop it over general surgery. Breaks it up immediately by diagnosis. We are coding 100% of our diagnosis in the HIS since September last year. I can pick any particular, I picked up 3 patients and I can see the names. I can see the bill amounts. I can see the procedures, the diagnosis, the procedures that were done because we are entering it all in the EMR. And I can export the whole thing. I can even see the patient demographics. Someone says, I want to follow up patients. This is a very common request. Show me all the hysterectomies I've done. I want to follow up. So we have the address. We have the telephone number. And I can, of course, export this or anything into MS Excel. That's it. So I've answered these things in a period of about 1 minute, no, 2 minutes, 2.5 minutes. That's the length of the video. And you will never imagine getting it otherwise. Diagnosis analysis. This is actually originally a 1-hour talk. I have had to compress it to 12 minutes. Just the clinical analytics part itself can be a full 20 minutes talk. But I'm going to show you only one demonstration video. I'm going to study a small period. So I've taken December last year. So I've got 57,000 patients. It showed me immediately. And I'm going to take diagnosis keyword. See, this is what we have done. We have reprocessed ICD and made it into keywords also. ICD-10 into keywords. So we have the original ICD as this. I'm going to study diabetes. And in that particular period, out of 52,617 patients, when I click, I have 285 diabetics. And now I put the, I'm searching for hypertension. So patients who have diabetes and hypertension is 174. Now I'm going to analyze these 174 patients further. By deceased episode, how many survived, how many died. One died. Of course, I can right-click and get the name of the patient. And out of the 173 who survived, age and admission ranges. And I'll see it as a bar graph. Yeah. So you'll see the peak is at 60 to 70, earliest is 30 to 40 years of age. So you can do your own clinical analysis. And the patterns that are in your area, we cover mostly Rajendra Nagar in New Delhi. Dashboards. This is okay for the person to come to the IT department, but we don't want him to come to the IT department every time. So if they feel this is a one-off report, they come to us. Otherwise, if they feel that they're going to get the report, use the report again and again, we make a dashboard, and that's it. They use it on their own. So they can interact with the dashboard. Dashboard gives them the data, and we can provide them key performance indicators, which we can give in the form of speedometers. So I've got two. Cesarean section rate. Now, cesarean section rate classically is supposed to be less than 35%, but I think private hospitals do tend to have it higher. I'm telling you actual statistics. This we have analyzed by unit, and you can see it is fairly high. This is the average. All these are individual units. This is the common one. And here I've analyzed patient by doctor since 2007. Actually, the whole thing took just about 5 seconds to display data from 2007 till date, doctor-wise. Each doctor's cesarean section rate. And we've actually managed to call some of the doctors and ask them why the cesarean section rate is so high. And lab income. After all, this is a business intelligence tool, so money does come in. So I'm going to study a 1-year period, 2010 complete, from January till December, and choose our genetic medicine. They have 4 departments. 2 seconds for 1-year data, and here you can see that performance lowest, highest, and this is most improvement, and this is getting worse. So you can find out which department is doing bad and catch them. So should all hospitals go in for a BI tool? Basically, what gets measured gets managed. If you don't measure it, you have an HS, you have a lot of data, but what is the return? You're not getting any proper information out of it. Hospitals have been data rich, but information poor. And really, IT investment in the form of HIS really had not done much for improving the strategic use of data until business intelligence came along. So HIS is just a milestone. It's not an end. Essentially, business intelligence is what provides a return of investment. So you put in a lot of money, you've got an HIS, don't stop there. And this message is for the CEOs and CIOs sitting over here. Don't stop there. This is just a milestone. You have to go ahead. Till you use business intelligence, you will not get a return. And I am aware, of course, I will stand corrected, of only 2 or 3 hospitals in the whole of India that are using business intelligence software. Most hospitals are running with reports. But this is the next wave that has to come in across India. Thank you.
It was an awesome presentation, Dr. Karamveer Singh, and that's where the future integration of clinics with clinical analytics with the business part of the hospital will have to travel. Our next speaker is Alok Baidya. He's replacing our original speaker who had Sushant, who had some personal emergency. Alok is a technology strategist with Microsoft and has been associated for driving healthcare projects across private sector and the public sector. He has around 15 years experience in developing and designing solutions for different organizations. Alok, thank you.
Thank you, Doctor. So while the laptop is getting ready, I would first of all really thankful to the organizing committee for giving us an opportunity to come and speak on this occasion.
We had a real good, interesting session in the morning. So we talked about real good things which matter in driving the organizational efficiency. So I just picked up a few words, personalized care, so that the patients really come back to you. And once the patient is given a better care, definitely you have patients coming back to your hospitals, which essentially you end up in getting more business to the organization also. We also talked about easy to use technology. So as an organization, just wanted to mention that Microsoft has been innovating technologies that are easy to use so that people start adopting technology the way they would love to expect. So during our course of journey, when we started off as an organization and then the way we have moved and evolved our software, we have also gone through the transition, and we have seen organizations also mature by adopting those technologies. So I would like to start off with a quick, very short video, which so I'll have to just make a small change, so we'll have the video later. So the topic what we thought of discussing today was to have a better understanding of how we can optimize the ICT investments which have already gone into really developing the organization, taking the organization to a next stage where technology is getting used. Now to start off, let me give you an analysis which was done by third-party agencies. If you see the way investments have gone into the organization, there has been a lot of investments which have come in. So whether it is to comply with regulations, whether it is to enhance the security, whether it is to improve the service levels. But what the analysis says that today, if you look at the way the infrastructure has grown, there is a lot of pressure than ever on ICT, that almost 67 to 70% of the investments are actually to keep on running that, whatever has gone in. So it's on the maintenance side. Only about 33% goes into new initiatives. It could be possibly in the areas which can drive better productivity. So it could be areas like increased productivity for health professionals. It could be improving results. We talked about business intelligence. So that's a great initiative for every healthcare organization to move into the next era of development. And with the ever increasing pressure on ICT, definitely with limited resources, the idea is how to enhance the performance, how to see to it that the organization really reaches out in a better way and give better efficiencies. As an organization, Microsoft has been focused on this one aspect, how to increase the efficiency of organization by using the infrastructure which has gone in a better way. So there are three pillars to this, the way we look at it. So one is the improving of efficiency itself. Then modernizing the health information wherein whatever are there in the current status, how can we move it to the next stage? And then definitely the whole aim is to improve the health and wellness of the organization. This definitely with an aim that whether it is the organizational employees who are involved or it is the consumers or my patients who are involved. So there has to be certain solutions or infrastructure in place which tries to map these two together in a way that the infrastructure really starts benefiting and IT is seen as an enabler to drive that business. Now for that, there are different things which we definitely think are possible. So few things we have already discussed in this session. One is, when we talk of optimizing the infrastructure, it could be anything related to the desktops or the devices what we use. It could be servers and data centers, the way it has been optimized. So we can bring in technologies which really makes them better usable. So things like virtualization, things like standardization on a desktop image, so that once you have a standard desktop image, this image can be used for bringing up devices or PCs or laptops the moment there is some issue. So you have a standard image with all the operating system, the applications all embedded into that image, and then the turnaround time for recovery or even rolling out new PCs, that becomes very easy. So that's one area, and definitely once this images come, you build on to that all line of business applications with possibly those connectors which would require to be connected at the backend for different backend applications. One specific area is the silos of information, what typically we have in an organization because of the different investments which have gone into automate the processes in one go or the other. Because when an organization grows from ground zero to the level where it is today, there has been a lot of investments which have gone in to bring it up to that level. So there could be silos of data repositories, silos of investments which have gone to modernize those components. So how do we really integrate that and build health integration and interoperability standards? The other aspect is when I have deployed all these components, how do I now start utilizing that and give better efficiency to my organization, both whether it is within the organization or for external entities or external consumers or my patients. Different solutions can come into play, say, for example, the case management, the health intelligence. We talked about health intelligence, especially the business intelligence part and the clinical intelligence. Or it could be even things like patient relationship management. This is one area which is really catching up nowadays because once the patient has gone out of the hospital, you really never know that the patient would again come back to the hospital until unless there is a real good mechanism to drive to a situation where the patient is given a personalized care. So, I mean, just to take a very simple example, so if a doctor has diagnosed possibly possible diabetes for a patient, and then he says that you are supposed to go through certain blood tests. Now, the patient, after he walks out of the chamber of the doctor, you never know whether the patient would actually go to that diagnosis center of your hospital to actually get those tests done. Now, after he has walked out of the hospital, he might go to his diagnostic center of his choice, get his tests done, and he might come back to the same doctor or might not come back to the same doctor. Now, there is definitely an initiative which goes in from the hospital side. So, say, for example, the hospital comes up with a diabetic week or a diabetic day. Now, because the information is definitely there in the HIS that these are the patients possibly that they had they could be having diabetes. So, how can the marketing team design campaigns very fast? How can they reach out and collect all communication happening with those patients with respect to that? So it could be inquiries coming in. And the beauty is that today applications are there which help all aspects of the hospital. So whether it is the contact center or the call center where people might want to call up for appointments, whether it is the repository where doctors can get access to the information which is there at the back-end system for patient information, all information can be given through a single console to the different stakeholders, obviously depending upon the security and the access. So the essence is, today if you have a 360-degree view of the patient, that gives a complete visibility of how you can improve the care to those patients. The other thing which we definitely think is the modernization of the health information itself. So we have talked about all of these. So whether it is electronic medical records, whether it is practice management systems, automating the imaging, and then definitely building a unified intelligence on top of that. So as Microsoft, there are a lot of accelerators available on our websites, which are called solution accelerators, which healthcare organizations can start using and then start building unified intelligence systems on top of that. And then reach out to the patients for better health services. The other aspect definitely is the data security and the privacy aspect, because that is one area where from organization perspective or from the patient perspective, both are important. So how do I increase the protection of my devices from, or possibly when people are trying to access the internal system from outside, access from anywhere, and still I give the kind of access. So things like network access protection, where the moment a person tries to log into your intranet or from home, it could be practically anyone. It could be your own employees, it could be your external consumers. You would see to it that the, whatever data they access are in a complete secure way. How can I integrate and extend security features across the enterprise? And then the security experience, if it really stops the user from utilizing or using the net resources, that is not security what typically anyone would like to deploy. Because if the user has to spend tons and tons of time in really understanding the implication itself, and then the user would get jittery about for using the technology. So while definitely the focus has to be on how to deploy the technology, how to make it more usable, the experience should also be seamless. So that's definitely one area where as an organization Microsoft has been focusing. And then one component which is definitely catching up nowadays, because a lot of organizations, when you are growing, you might not want to invest in the infrastructure for all of the components within the premises of your organization. It might not be necessary even. So, for example, your HIS system could be located at a central place, while your other applications, which could be, say, for example, an email, which possibly is just a requirement that for the productivity purpose, just for communication purpose, it might not be hosted within the same data center. You could host it on a cloud-based system. The systems which typically might be required to be hosted on premises could be some things like departmental systems or EMRs. So essentially what we are trying to say is, today you have the flexibility to have an infrastructure which gives you the platform continuum and gives the seamless experience to the users as well as the IT administrators. So you could have on-premises infrastructure, you could have off-premises on the cloud infrastructure, and all working seamlessly. And today we are proud to say that Microsoft is an organization which gives you the flexibility to have an infrastructure which traverses across the infrastructure which is there in your data centers, or it is on a private cloud, or on a public cloud. That's the kind of flexibility which the technology can provide today. So we started off yesterday by talking of an evolution. So Mohammed spoke about the evolution that the country got. We also talked of the different evolutions which the industry saw. So the essence, what we are trying to bring out here, the evolution of the technology has already started, and it's in progress across different organizations like you. So here are some examples of different organizations who are already doing these kind of exercises. Say, for example, the Achieving Health and Wellness has been one of their vision to have a complete end-to-end solution from empowering patients and their care team. So these are the certain case studies which are published on our websites, which gives a good visibility of how organizations have evolved and really optimized on their investments and then moved ahead. To summarize, this is what essentially we are moving to. An era where we see that the investments which have gone into the organization goes a step by step. So the first step could be a modernization of those investments, and then moving to a situation where you give ownership to the consumers as well as the internal organization to really look at the way the things should happen, and then move to an era where possibly cloud computing is one place which people can start looking at. So the time of transformation is definitely, first of all, to optimize on the existing investments, improve upon all of that, and then transform the way IT is seen within an organization. So IT should always be seen as a business enabler, and then move to the next step. So that's about my presentation. So I'll just quickly take, it's a 1 minute. So this gives you a quick glimpse about the evolution of within a Microsoft itself, and then how the organization, the sound? This was to just give a glimpse of how, as an organization, Microsoft also evolved, and the way the technology helped even a person evolve from an IT manager to the CIO. With that, I would really thank you for giving me the opportunity. I would insist that there's a feedback form out there which helps us to innovate on the technology. Please do fill that, and please do feel free to come back to us in our stalls. Thank you.
Thank you, Alok. Wonderful presentation. And we, as you notice, all of us speakers are uniformly overstayed the red light. And I'll do the same. I'll try not to do the same. I'm going to talk about improving healthcare affordability with next generation EHR and ICT. And it's from the trenches. I work in trenches in 21st century USA. And my group works in about 1,000 villages in UP with the 13th century hardware, which is the human beings there. So I'll see how we can increase affordability across the board between countries which are separated by centuries. And now to begin with, I'll answer only 4 questions in this presentation. What improves affordability? What is the next generation EHR? What are the IT tools we use for these purposes? And a couple of examples how it may come out in practice. 3 objectives at 3 levels can improve affordability. We have to create something at the individual level. We have to decrease disease burden at the community level and align healthcare finance structure at the national level. I'll go with the first one, optimize cost for outcome, the cheapest way to deliver the best care, cheapest in the sense of inexpensive way to deliver the best outcome. What tool do we use? The EHR. Now the problem with the current EHR is it has the edifice without the foundation, and the foundation is missing. Foundation should have been the clinical evidence and the clinical data, cost management, outcomes, and risk management. But what we have in a current EHR is the revenue management, some clinical data, demographics only. So unless the bottom 4 that you're missing at the at the current EHR, the EHR is not complete. Now, current EHR provides payer rules. Healthcare finance, whether we like it or not, it drives healthcare. How the financial structure is exactly how people practice and deliver healthcare, whether it's the public finance or the private finance. The EHR lacks the payer rules. What are the criteria? What is the item and cumulative cost? The single most line item thing that can improve healthcare is a person, a provider level, at my level, if I knew the cost of each thing that I'm prescribing. Doctors are most ignorant about the cost of care they prescribe, including the cost of medications. Payer coverage, length of stay, expected payment, etc. Now, provider EHR needs decision support. We talked about it, business intelligence decision support. Now, I want to marry business intelligence with the clinical intelligence. So we need information, we need knowledge, and of course we need wisdom, which somehow the other is always lacking. And it has a cost component to lack of wisdom. I'll get in that in a minute. What we have at the moment is available in the EHR and the systems is the middle panel, middle vertical that you see is the knowledge. In that we have the diagnosis, investigations, therapy. But again, clinical evidence and comparative effectiveness is lacking in that. We have some information, but we do not have quality standards and legal standards built into the EHR at the moment, the risk management idea and the safety issues. And wisdom, the third panel, the vertical is completely lacking. What is the prognosis? What is the quality or the quality adjusted life years? What are the ethics involved? End of life. Now, end of life is extremely important, cut down the cost. Something like 27% of healthcare cost goes into last 23 days of life. So the wisdom panel should be part of the EHR. Now, second way to decrease cost or increase affordability is by community and a personal health record. I call it the CHR and the PHR. Now, I want to define affordability here. I mean to the patient, affordability to the patient and to the community or the nation. Cutting cost may increase the profit of an organization, does not necessarily make it affordable to the consumer. By affordability, I mean here is affordable to the patient, which is really what drives the access and the availability. A community health record, which is part of the EHR, will improve affordability by various means, which we all know that it avoids duplication, avoids various other ills that are associated with current health system. And of course, it provides the community health literacy. My favorite bit in here, health literacy, the community is the least expensive way of decreasing disease burden. As I mentioned at the end of my speech here, what I mean by that. CHR functionality, information decreased disease burden, is social determinants of health, extremely important. Is there water, sanitation, poverty, which is never mentioned in any kind of a EHR module. Immunization status, the only things, very few diseases that we can prevent is because of immunization. Maternal mortality, health indices of the society, preventable disease prevalence, because the first function of any health system should be prevent the preventable. Second should be cure the curable. But most of the health infrastructure is attempted to cure the incurable. That's where the big money is. Prevent disease prevalence, various kinds of social habits. Environment pollution, for example, is extremely important as a part of the community EHR, health literacy and data mining for the community. And of course, we share the infrastructure, the various things, the infrastructure information on the EHR itself. Now this EHR, the community health record, has to be interfaced to the personal health record. That will solve the problem of what was mentioned earlier of a consumer going through the health maze and not knowing what's happening. The information is not available. And one of the speakers mentioned, Arvind mentioned earlier that his wife entered the hospital and nothing was known to anybody, which is a current problem. And now PHR, which could be even a handheld device, which is connected to the hospital EHR, the community EHR, gives you real-time information what's happening to it, and also provides health literacy. You can incentivize the individual for involvement in his own personal care, and of course the drug list, the problem is the allergies and so on and so forth, and it can interface with home devices. Now this is from Kristen Wolf in JAMA, published a month ago. PHR. Now PHR, incidentally, the gadgets are already available. There's a PHR that's developed by CTIS in Washington, D.C. It works on iPhone, it's connected to the Google Health. It's in the market now. It's a free application. You can download on iPhone now, and they're going to Android by the end of this year. So this is 5 levels that Kristen Wolf recommended in the PHR. First, the demographics, then integrate PHR with EHR, deliver information to Arvinds of the world in simple language, provide individual recommendation for maintenance of health, and give decision aids, messages, follow-ups, etc. Now I want to come to next generation EHR. When we marry these 3 health records of an individual, that's what I call the next generation EHR, and that's where we should go faster the better. The PHR is the personal health record by the individual. EHR is the current EMR, EHR, whatever we use by the provider, and a CHR is the public health information, all matched and married for the next generation EHR. I want to give you one example. It's a very busy slide, but I want you to concentrate on the top thing. How do we use this EHR to optimize cost? Now you can optimize cost if I as a provider knew what the cost of transaction is, which is not available. So at the very transaction level, this information should be available. Let's take evidence of, this is first column is event, evidence alternative, cost, and does it meet the standard of care. Now event intervention, I've taken a simple example of a person comes with chest pain to a hospital, and there are certain events that take place. It is not to say that this is a real pathway, but it's just an example. Now we have, let's say for example, a coronary angiogram and angioplasty done on a chest pain patient. It depends what is the evidence that this is going to benefit. It depends on the size of the lesion, the site of the lesion, and there's plenty of evidence already available which is going to benefit or not. It should be available in real time while I'm writing the diagnosis. And of course, standard of care we meet if it's indicated. Let's take the drugs that we do. These are the drugs that are prescribed at the moment. There's plenty of evidence they'll decrease the second heart attack. Do we generic and brands, what's the cost? And does it meet standard of care? So this is kind of a grid that'll tell you what I mean by giving real information. Let's take stroke, one more example, which tells you the continuum of care between the community health care, the hospital care, and the personal health record. The patient does come to the community. If there were provisions of decreasing health, disease burden, it's quite likely we will decrease the incidence of stroke. For example, we know now that particulate pollution in the healthcare, particulate pollution in the atmosphere will decrease the strokes next day or the day after. It's their population studies done now. So if there were a particulate matter which exceeds a certain limit, and people with the hypertension and diabetes, or people at high risk, we should be recommending them stay indoors for a day or two, probably avoid stroke. But if there's a stroke that has happened, then we also know by the fast transportation within first 90 minutes to the hospital can make a difference between life and death in a person. So this community EHR connected with the hospital with a fast transportation service, and the first 90 minutes of care determines the outcome. And of course, to prevent the second event, you need to be connected to personal health record, behavior modification, give up smoking, lose weight, etc., etc. Now this is a summary of what may happen, the cost. The PHR, health literacy and prevention. CHR, decreased disease burden. Current EMR, EHR, the hospital EHR, lower the length of stay, prevent readmission to cut the cost. And outpatient PHR for disease, chronic disease management. Now EHR is a dynamic process. It's not that we made one and go back. It's a continuous process. We start with EHR 1.0 or 2.0 here, and there's a connectivity mobility platforms come into play, user interface, which is extremely important for people like me that want to save time in a hospital care, and they have to be interoperable. And this is a constant systems integration process. Innovation has to be a constant process in there. And it has to be evidence-driven decision support system that evolves to next generation EHR, and the cycle goes on and on. Now, they don't have to be in sequence. They can be in parallel while we're evolving the next EHR. Now, here's the key to the whole thing. How do we design a healthcare finance in a society to deliver the best care and make it affordable? And what ICT tools do we use? This is the macro sense. Third objective. The problem with current healthcare finance is that healthcare finance collects the funds either from private public source. It is pooled in a risk pool like an insurance company. The insurance company then purchases healthcare from the provider or the hospital, and the consumer then utilizes the premium paid in terms of healthcare delivered. The problem, the fund says, all is a resource constraints in any country in the world. Goal of risk pool is to minimize medical costs to enhance the profits. Care provider wants to maximize revenue by demand inducement, and the consumer expects more, what's called the moral hazard in health economics. Now, the funds are limited, and everybody is grabbing those funds. Risk pools want to maximize the bottom line, provider induces demand, and consumer uses the moral hazard. The problem with the funds is they are limited. So what do we have to do? We have to use ICT mechanisms right here. The consumer, provider, and payer have to be aligned. This is where the ICT comes in. We have to focus on processes and outcomes, predefined outcomes, and then whatever money is left at the end should be shared between the three entities by the consumer, definitely by decreased premium and the incentives. Now, here's the current scenario. We have the source of funds, mostly private in the world. India has 74% out-of-pocket expenses at the moment, which is private. We have multiple pools, we have multiple prices, we have multiple in the vendors. The alternative structure that I'm suggesting is it should be mostly public funded. It should be one integrated national pool and a national plan of how do we utilize the whole money pool that's available. And of course, it can be multiple pools in there, but under one guided plan. And there should be uniform standards of payment and multiple competing. Now, what are the ICT tools that we can use in each vertical segment here? The list is here, and all we have at the moment is this billing and revenue cycle of the provider. All these rest of the things are lacking, and which is where we had to go fast. Now, here's a slide that Dr. Thanga Prabhu used yesterday. This is from a group that we worked with called Indian Health Information Network Development. This paper, concept paper, was prepared for National Knowledge Commission and then for the Ministry of Health. Is lying in the bureaucratic inertia in Delhi at the moment. And hopefully we have said that everybody should be connected based on the model that I had described earlier, and hopefully we'll do it someday. Now, this is the organization that I worked with, which works in the villages of UP. We cover about 1,000 villages of UP. And here's the wisdom part of the panel that I said in the decision support. Our question was, do we use money for creating IT infrastructure, or do we use money to decrease maternal mortality? Outcome is only one. How do I save 18-year-old mothers from dying during childbirth? When we started 3 years ago in this area, 1,000 villages, the maternal mortality was 645 per 100,000 live births. We have dropped it by 93%. Our maternal mortality is close to 40 now in less than 3 years in 1,000 villages at a cost of 5,000 rupees or approximately $100 per village. And guess what? We have no ICT. So the wisdom part is extremely important, that you have limited money. How do we use it to optimize outcomes? Now, ICT would be great if it came within the same cost. Thank you. Now we'll take questions. Professor Ganapati, do we have time?
10 minutes.
All right, 10 minutes. We take questions quickly, and my red light wasn't on. Thank you. And questions, please. Any comments? Yes, sir.
Can you please announce yourself?
Please identify yourself,
This entire
sir.
program is being webcast. I think that was not reiterated strongly. This entire program is being webcast right from yesterday morning, and I'm told there are a pretty large number of people from all over the world who are seeing this live.
My name is Samir, and I have two questions for Dr. Karanveer. The first question is, you mentioned there are about 2-3 hospitals that have adopted BI. And I was wondering what is the reason? What prevents other hospitals from adopting BI? Is it the cost, or they're not very keen on arriving at the advantages that BI offers and data mining? That's my first question. And the second question is, can you briefly mention what were the features in the data mining tool that you have used and link them to the real benefit that the hospital experienced?
Yes,
thank you.
Quite a few slides on this. The first return of investment, the first one when we had just started this was when we analyzed the packages that the hospital offers for gynecology, for cardiac surgery, etc. And we found that in some packages, the money that we were spending within the package was far more than what we were taking from the patients. So we changed the package. And in a lot of packages, we were making an inordinate amount of profit. So that means we were overcharging the patients, and we could cut the package price. So we cut the package price. And we made our packages more competitive with the market. So the throughput, definitely we found it increased. And the best part was that actually when the throughput increased, you could even using speed miner see the throughput increasing. So we knew that not only had we reduced the package, that it actually had an effect. So that was it. And then, of course, analysis of doctors' performances. We know who's bringing in more money and who's not, so we can regulate it. How do we regulate? We provide more beds to the person who is getting in more patients, rather than have one doctor who's bringing in hardly any patients have 3 beds, and those beds are not being utilized. So we move those beds to another doctor who's bringing in more patients. So we optimize our bed utilization. Gangaram runs close to 100% bed occupancy. And for us, juggling these beds is really important, makes all the difference. There are lots of examples. I mean, offhand I can just remember these two. But like I told you, I think there are about some 30 slides that I had deleted from it, which detailed all these. But we recovered the money in 2 years. The total cost of the software we recovered in 2 years. And it is this software that told us that yes, we had recovered in 2 years, because we got that data.
Hi, my name is Sri Hari. I represent Sharp Software. This is to Dr. Ganju. In fact, I was quite thrilled by, you said, prevent the preventable and cure the curable. Of course, there is a lot of curative, whatever we saw all these 2 days was more on the curative part of it. Very little on the preventive care. I know that, there is a lot of chronic diseases which are right into the rural heartland, like, for example, diabetes. One of the questions I have is there a formal practice of prevention? Is it going to mature soon? And second one, can it be monetized such that other corporates can get in if ICT technologies can help?
Now, prevention. There's no money making prevention, so everybody neglects prevention. There's no ROIs in prevention, so there's no investment. Even in the US, less than 1% of the total healthcare budget or the healthcare spend, $2.4 trillion is spent on prevention. Second is the lack of knowledge. There aren't many diseases we can prevent, even though there's hype about it. Now I'm talking primary prevention. By immunization, they're probably the only diseases. In adult age, we postpone diseases we can't really prevent. We postpone stroke, heart attack. We really don't have the knowledge to prevent. The only disease in adult age we can probably prevent is colon cancer. So it's a lack of knowledge and lack of investment both. But then at secondary and a tertiary prevention level, we have enough data and knowledge to do it. In other words, if you are a diabetic, can we prevent the kidney failure? Can we prevent blindness, etc.? Or we have early detection mechanisms of breast cancer, prostate cancer, and so on. The disease occurred, but can we then prevent the complications of the disease? But the problem is, like I said, is the investment, and there's no money involved in there. So it is a do-good approach now. People who have a little fire in the belly go out there and say, let's prevent some diseases, because prevent the preventable and cure the curable are the two. There are only 6 things medical systems do. We prevent the preventable, we cure the curable, we rehabilitate the disabled. And then we attempt to palliate the incurable, which should be the paradigm as opposed to trying to cure the incurable. And then we provide comfort at death. That's all the 5, 6 things we do. It's very simple. So all the investment should go into prevent the preventable and cure the curable, and not trying to cure the incurable, which is what the medical industrial complex is built on.
I have a question for Dr. Bhattacharya. I am an oncologist in Tata Medical Center in Calcutta, and my question is that what are the regulations, if any, on patient data security in India? Patient privacy and patient data security in an EMR setting?
You're talking about the regulations, right?
Yes.
Well, the regulations are not yet there in place, to be honest. What we do is, I'll tell you what we do. We almost blatantly follow whatever that is being done in US, and we give it in our solutions. I'm not talking about just my company. I mean, all the companies, they try to do that. What you basically have is a role-based access control. And that too is not very, very secure. But there is no government regulation or any, so there is no need for you to go into any compliance. I am told that the IT Act 2000 has some provisions, but that is nothing specific to EHR or EMR. That is just general privacy, security, and all this sort of stuff.
And when you're talking about role-based in a hospital setting as opposed to a private clinic where you know that this is a person's doctor, in a hospital setting where a lot of people may need access to a patient's clinical data, do you face challenges, or do you have any examples how other software providers have tackled those challenges? Because I worked in Canada, and I know that to a large extent EMR was open, but there was a lot of access tracking and that kind of thing. What goes on in other parts of the world?
Well, in the other parts of the world, it is all role-based. So the problem, the thing is this, that you are talking about, if you are talking about in Indian context, there are very few EMRs that are being used enterprise-wide. There are a few hospitals, and they have role-based access control. But it is not as strict as they are followed in US. But in the rest of the world, there are various state regulations which are in place, and they have to be complied with.
Thank you. Yeah.
I'm told we are out of time now. Thank you very much for participating, and that's the end of this session. Thank you.
Thank you to all the dignitaries, but I request you to please be on stage, as we'll have our chairperson of this session give away the mementos to the panel of speakers. Could we please have the mementos?
We could have utilized that time for questions. Make it faster.
And I'd also request Mr. Scott E. Campbell, the Executive Director and CEO Foundation for NIH USA, to please come up on the dais and give away the memento to our chairperson.